Hi, Dr. Zen.
Hello.
How are you today?
I'm doing great. Thanks for the
Good.
invitation to
Thank
be
you.
here.
Yeah, and thanks for being part of our conference. Very generous of you to offer your time today. And we have a lot of people very interested in brachytherapy and alternatives to external beam radiation therapies. So we'll get into this instantly as soon as you tell us what kind of doctor you are and where you practice.
Sure. My name is Jing Zeng. I am a radiation oncologist, and one of my clinical focus is in prostate cancer. I am here in Seattle with the University of Washington School of Medicine, Seattle Cancer Care Alliance, as well as our Proton Therapy Center.
So how many days a week do you actually have a patient sitting in front of you?
Sure, 3 days a week, actually. I became a doctor to be a doctor. And so I spend most of my time taking care of patients, but I run a number of clinical trials, including in prostate cancer as well. And I engage in a number of research projects so that hopefully we can cure more cancer one day.
Yeah, and I ask that because there's so many conferences and presentations that are done by people, fine and good for them. But I mean, that are, research-based guys and women that,
Sure.
and maybe see patients peripherally to their, their life and love around research and discovery. This conference this year is, we want people who have people in front of them. And of course, the paradox is absolutely nobody is here. It's just us and a laptop, So let's start with what radiation is. I mean, and what is it? I mean, we understand what surgery is. It's cut it out.
That's true.
But right. What's radiation doing to disrupt the prostate cancer?
Yeah, that's a good question. And I agree with you that I think people have an intuitive understanding of what surgery is, right? Like you said, you cut it out. But I think a lot of the time, the word radiation is terrifying to people. And, what radiation is, it's really energy. It's high energy in the form of usually X-ray particles, although it could be other forms of particles as well. And the goal of radiation is that we focus that very high energy on the cancer so that hopefully we kill off the cancer cells, but leave enough of the normal cells intact so that you still have good function afterwards. So your anatomy remains the same in that the prostate is still in place, but the hope is that we killed off all the cancer cells in the prostate, but left, the urinary tract intact.
Right. And the idea of energy and particles is also kind of abstract. I mean, it's, we get energy from the sun. We sort of understand solar panels, but this is different than, even though the sun can burn our skin, tell us how it's different.
Yeah, so, a lot of the time, a lot of radiation treatments, it's kind of like getting an X-ray, right? You go in, you get an X-ray, they shoot a beam of X-ray at you and you can see inside. And a lot of radiation treatment uses the exact same kind of X-rays, but it's higher energy so that instead of just shooting through you to get you a picture of what's going on inside your body, it's actually doing damage along the way. So it basically, we think the radiation kills cells by damaging the DNA in the cells that it's hitting and therefore causing cell death. Now, your normal cells are very good at repairing DNA damage. Like you mentioned, sunlight, you can get it burned, but you'll heal. And so the goal is that your normal cells will heal from the radiation and still be functional afterwards, but the cancer cells will not, and they'll be killed by the radiation instead.
And why is it that cancer cells are so vulnerable?
Yeah, so in order to become a cancer cell, it has to figure out how to grow without, having the usual checkpoints that your normal cells have. And so it does that by mutating its DNA. So it is intentionally not as good at repairing DNA damage as your normal cells are. And that's where the radiation comes in, because the radiation causes DNA damage. And so hopefully we're exploiting that weakness, kind of that special characteristic of the cancer cells, that we damage their DNA, they cannot repair it. Whereas if we're also damaging your normal cells, they can repair that DNA damage so that they will recover and function normally afterwards.
Yeah, and that also that illustrates like another paradox in our maybe paradox will be the main word of our chat today, but the idea that we think of cancer cells as these super evil beings, these super, and like they're going to take over our body, but actually
parasites. That's right.
Right, parasites, but they're really they just don't know how to fix themselves like the rest of our healthy cells, so to speak.
Right.
And the healthy cells are healthy because they can repair. They have
Mhm.
mechanisms that cancer cells don't. So
Right.
radiation in a way exploits that. Is that fair to say?
Exactly.
Yeah.
Yeah.
So there are different kinds of radiation.
Sure.
Why is that?
That's a good question. I think the goal of radiation treatment, probably like any other cancer treatment, is always we want to kill all the cancer cells. And we would like to kill as few of the normal cells as possible. And so there are different ways to do that. I think, when people first start thinking about radiation treatment, usually there's kind of one big fork in the road. One is called external beam radiation, and one is called brachytherapy or radioactive seeds. Hence, I think the title of our conversation today, to seed or not to seed. For external beam radiation, it feels a lot like getting x-rays, meaning, the source of the radiation is outside of your body and the beams are kind of coming at you. Whereas for brachytherapy, we're actually putting something radioactive into the body, either temporarily or permanently. And so we call that brachytherapy. So,
And
go ahead.
Oh, sorry. No, you go ahead.
Yeah, I was going to say, both forms of radiation have existed for many decades. I think the goal of, I think one of the advantages of external beam radiation is a lot of the time people don't like the idea of something radioactive going to their body. But what the term external beam radiation suggests is the radiation has to shoot through something to get to something that's in the middle of the body, like the prostate. It does have to travel through a bit of the bladder, a bit of the rectum in order to make its way to the prostate. Whereas for something like brachytherapy, you have the advantage of you're actually directly putting the radiation inside where the cancer is, so that hopefully you're getting less radiation to the rest of the body, like the bladder and the rectum. So I think it's two ways of trying to accomplish the same goal. Sorry.
Right, but the way you described it sounds that the way to go for almost everyone is brachytherapy. Then why do we have this fork in the road?
Yeah, so I think there are definitely physicians out there who feel that way, who feel that brachytherapy is the best treatment available. There are many studies that show that from a cost effectiveness standpoint, it very well may be, in that it's one of the least expensive treatments, but it's as good at taking care of the cancer, at curing the cancer, as the other forms of treatment there are. I think the first thing I would say is, the treatment that you need depends on the stage of the cancer, as well as you, meaning what kind of medical conditions do you have? What is your current urinary function? What is your current bowel function? What is your current, sexual function? So I think that differs a bit from patient to patient, and that can influence which treatment is best for you. But with brachytherapy, yes, it's been around for many decades. They have made a lot of technological improvements over the past several decades. So brachytherapy is constantly getting better as well. So I think men come to us with very strong preferences for what they do and do not want to do. And so I think, there are multiple treatment options that are out there that are equally good. And it's just a matter of talking to your doctor about figuring out which one seems to match best with your priorities and your interests.
So when you say you're asking about urinary function, sexual function, I mean, these are all the critical side effects, and erectile function.
Sure.
I mean, the critical side effects that are at the front line of concern for all, prostate cancer patients.
Of course.
Is that, but that line of questioning suggests that one form of therapy is external versus brachy, or internal, let's call it that for a brief second, is superior at preserving, at not harming us side effect wise. Is that valid to say?
Sure. So I think the long-term effects of both the external beam therapy and brachytherapy are quite similar. I think, the brachytherapy, because you're physically and geometrically putting radioactive seeds inside the prostate, or radioactive sources inside the prostate, it does face some limitations that external beam radiation does not. Meaning, one very common one is prostate size. The larger the prostate, the more number of radioactive seeds that needs to go into the prostate, and it becomes harder to provide even radiation coverage to all the prostate without overdosing being, for example, the urethra, which runs through the prostate. And so prostate size is one potential limitation to who can have brachytherapy and who cannot. Another one is often urinary side effects. Some think that brachytherapy can lead to a slightly more intense urinary side effect right after the procedure. And so if someone comes to us with a lot of urinary, symptoms already, we may be concerned about their ability to get through just a very initial stage of the brachytherapy treatment. And so there are a couple more selection criteria for brachytherapy compared to external beam radiation. I think another, very unfortunate effect of another kind of unfortunate trend that's been happening over the past few decades for brachytherapy is that external beam radiation, it's easier to perform than brachytherapy. Brachytherapy, it's kind of like a surgical procedure. It's very technical. And so you have to be trained to do it. And like all procedures, you want someone who does it on a fairly regular basis so that they're kind of a high volume, high expertise person. And not every radiation oncologist can necessarily do brachytherapy well. Hopefully all radiation oncologists can do external beam radiation very well, especially for a relatively common cancer like prostate cancer. But brachytherapy, you can definitely see large differences in quality based on how used to someone is, based on their level of expertise. And so it kind of feeds into this pattern where if you don't have as many people that are good at it, then they don't do it as often. Then you have trouble teaching it to the next generation of radiation oncologists. And so then you have fewer people that are good at doing it. And my apologies, my computer actually just logged out, so I can't see you. I don't know if you can still see me.
Oh, I could see you.
Okay, good. I'm back, and you're back now too. So,
okay. Good. Okay. And that's good because people want to see you. So, I mean, maybe a good way to sort of do this deep dive into brachytherapy and seeding is to start with imagining a patient and follow through on their concerns, but also what is it that you actually are doing? I mean, so patient sits in front of you and somehow you both come to an agreement, you've shared your decision-making in a classic way, brachytherapy's on the table. Now what, but there are different kinds of brachytherapy and there are different things for you and the patient to have to decide on. So what are those things?
Yeah, so, I mentioned earlier that the technology for doing brachytherapy has actually evolved over the past years as well. So the traditional way that we did brachytherapy for decades is what we call low dose rate brachytherapy, or LDR is kind of the acronym for low dose rate. And what that meant was that usually a patient comes in and we do an ultrasound of the prostate so that we can see what's the size, what's the shape, are there particular tumors that we're worried about inside the prostate. And we will then map out where do we need to put little radioactive seeds inside the prostate so that we make sure we're covering the entire prostate and killing all the cancer cells, but we're not overdosing the normal organs like the urethra that travels through the prostate, or the bladder or the rectum, which sits right behind the prostate. So you usually you do a pre-plan and figure out this is where all the radioactive seeds need to go. And then the patient comes in, there's usually some kind of either local anesthetic or more general anesthetic kind of in the operating room. They come in for that procedure. It feels a little bit almost like a prostate biopsy procedure where, we then kind of use the ultrasound again so that we can see the prostate and we make sure that we're inserting those radioactive seeds to the position that we calculated they need to be. And we're monitoring where the seeds are going as we're inserting them. And oftentimes we're adjusting what the radiation plan looks like based on where the seeds actually are to make sure that when we're done with the procedure, that the radiation is going exactly where it needs to go. So for patients, that's kind of a one-day outpatient procedure. You come in, you get the procedure done. It does take a few hours to get it done, but then you get to you wake up and you walk out and you go home afterwards. So that's what low dose rate brachytherapy is. Now, one of the kind of things that people have not liked about the procedure is that you're left with these mildly radioactive seeds in your body. And the radiation activity drops off very quickly over the next few weeks after we put it in. So it's not as if you're permanently walking around radioactive, but you are very, very, very slightly radioactive in the prostate area for the immediate period of time after the radiation treatment. And so in the more recent years, there's been technology that's been developed so that we can now do something called high dose rate brachytherapy, or HDR. And what that is similarly, we use either ultrasound or CT scans or MRIs so that we can see the prostate. And we calculate, we're going to insert catheters into the prostate so that we provide good coverage of the entire prostate area. And we temporarily use a very high dose rate radioactive source into each one of the catheters. It will, for each one of the positions inside the catheter, it can remain for a few seconds or even, maybe a minute. But we calculate where does that radioactive source need to go inside each one of the catheters so that we provide radiation to the prostate, but then the radioactive source is removed and so are the catheters. And so you get the radiation again in kind of an outpatient one-day procedure that takes a few hours, but you're not left with anything radioactive inside your body. So the improvements in imaging technology and the computation technology has allowed that to happen. So that's kind of the first major decision in brachytherapy, which is, are you going to be treated with low dose rate brachytherapy or high dose rate brachytherapy? And both seem to be equally good at curing cancer. So, external beam radiation, LDR brachy, HDR brachy, they all seem to be equally good at curing the cancer itself. So it really comes down to choosing kind of the logistics of the treatment and the expected side effects.
So, and the expected side effects are comparable, or HDR is slightly better odds?
So, I think when you look at the long-term side effects of urinary function, bowel function, erectile function, it seems like they're all comparable. Again, with brachytherapy, there's the thought that temporarily in the immediate post-procedure period, you might have slightly more urinary side effects. And that's why we do hesitate to offer it to someone who has a lot more urinary symptoms prior to the radiation treatment. But the long-term side effects seem to be quite similar.
With both of them, the patient goes home with the catheter?
Temporarily. So a lot of the time patient will go home with a catheter overnight, but they'll come back the next day and have it removed. Occasionally, we also will do a voiding trial in the clinic where, we remove the catheter, make sure that you're capable of urinating. And then if you are, you're able to go home without one.
Okay. So now let's get dirty about this. The idea of, so with low dose rate, you have seeds inside you.
Sure.
Okay. Very quickly, like in 90 seconds or less. I mean, what are those seeds? What do they look like? I mean, give everyone like a really clear picture of what
they are very, very small metallic, objects that are smaller than a grain of rice. So they're permanently, but you don't feel them, you don't see them. And like I said, after the immediate few weeks after the radiation, after the brachytherapy procedure, they are no longer radioactive. So you can go to the airport. You're not going to set off radiation sensors, et cetera, after that very first initial period.
So it's emitting radiation. What's the sort of, I was going to say critical difference, but I mean, I'll let you come up with an adjective. What's the difference between emitting from the inside out or emitting from the outside in terms of side effects, damage, and effectiveness?
Sure, that's a good question. My apologies for not mentioning it before. With the radiation beams that we shoot from the outside, they have to be very penetrative. They have to travel through tissue to get to the prostate. Whereas the kind of radiation that are in those radioactive seeds that we give for brachytherapy, they're radiation that's not meant to travel very far. They are not meant to travel further than a few millimeters. So like an eighth of an inch, less than a quarter of an inch kind of thing. And so, the surface of your body should be getting virtually no radiation at all. So the thought is that, yes, the immediately, touching areas like the very bottom part of the bladder, the very front part of the rectum will get a little bit of radiation dose. But as you move more than, half an inch away from the prostate, your organs should be really getting very, very, very low dose radiation, virtually none at all. So that's the benefit of brachytherapy, because we're actively putting something radioactive into you and it does not travel far. You're really intensely concentrating the radiation in the area that we put the radiation into.
And your goal with both low dose and high dose is to radiate, is to disrupt cancers, is to affect this in the entirety of the prostate. Is that right?
That's right. I think, there's definitely some, definitely for patients who are initially diagnosed with prostate cancer, the goal is to treat the entire prostate. You're certainly capable of using the radioactive seeds to treat just a portion of the prostate, but there's always the fear that you're going to be missing something small in another part of the prostate. So it's not currently routine for us to only give brachytherapy to a segment of the prostate, unless you're talking about a special salvage situation, like someone who's had radiation before and the cancer is back in a small part of the prostate. They can talk about it, but that's not very routinely done. So usually our goal is to treat the entire prostate with the brachytherapy.
So with surgery, when you cut out a prostate, you've taken out a prostate and the seminal vesicles and
Sure.
associated stuff. So I mean, you put it out, you put it in a bag, you send it to the pathology lab. They're having fun with it and get all these reports and stuff. Brachytherapy, how do you know you're actually hitting everything inside the prostate?
Yeah, good question. So, the brachytherapy in this day and age, it's all done with image guidance. I had mentioned ultrasound, I mentioned CT, I mentioned MRI, but all different ways to actually be able to see the prostate to make sure that when we're giving the radiation, we are indeed covering the prostate. For long-term monitoring after the treatment is done, just like if you had surgery, your surgeon might say, I got it all, you're cured, it's out in a bag, but they're going to monitor your PSA for years afterwards to make sure that they indeed did get it all. And similarly for radiation, we would need to monitor your PSA for years afterwards. Now with radiation treatment, because you still have a prostate in your body, and some of the normal prostate cells may have survived the bombardment from the radiation treatment, you very well may still have a PSA value that's not zero, because some of your normal prostate may have survived and they're still making PSA. But we do expect to see your PSA dramatically drop after the radiation treatment. And most patients will eventually settle with a PSA kind of in the 1 or less range. So that's what we want to see after the brachytherapy as well, a drop in the PSA and then kind of leveling out forever at a very low rate.
Right, and it sort of raises another sort of misconstruction that we're not out to, even though with surgery, the goal is 0 PSA because there's no prostate. But in fact, a healthy man or transgender woman with the prostate will have some PSA measurement throughout the course of their life, even if there isn't a single cancer cell ever.
Of course, exactly.
Right. So the reason a post-radiation therapy patient would have is because you're now looking at what your healthy prostate should be producing or measuring out. Yeah.
Exactly. Some of your healthy, normal prostate will have been damaged by the radiation as well. And so that's why your PSA will be low, but it's not alarming for there to be some PSA value after radiation. It's expected because some of your prostate will have survived. But as you mentioned, a normal prostate shouldn't be growing anymore. And so whatever that PSA value is, we just want to see it stabilize and level out at some low value forever moving forward.
Right. And that value is commonly called the nadir, is that right?
Exactly. Yep. Because we know that after radiation, it's not, the radiation can take several months or even a year or two for it to continue working. So you'll see the PSA drop for several measurements after the radiation treatment. And it's okay for the first value to still feel high as long as it seems to be on a downward trajectory that's dropping. So, but when it reaches its lowest point, we would like to see it stay at that level moving forward.
And why is it that it takes time?
Sure. So, as mentioned, the radiation goes in and does a tremendous amount of DNA damage. And we hope that that means that the cancer cells are basically no longer viable. They cannot go on to grow and reproduce. But it takes time for them to die. And that can take several months or even a year or two for it to continually happen. And as they are dying off, including some of the normal prostate cells in the area, then their PSA will continue to decline.
And so again, like for getting really good pictures in our head, When a cancer cell dies, when a clump of them die,
Mm-hmm.
I mean, they're still in the prostate. I mean, what does that look? What's going on?
Yeah, that's a good question. So, your bodies, we all have dying cells inside of our bodies on a regular basis, right? You can see the skin cells shedding off on the outside, but inside our digestive tract, we're shedding cells. So we constantly, our bodies are very used to digesting away dead cells and renewing with new cells. And so when the cancer cells are dying, your body's immune system will actually go in and clean it up and digest it away and, recycle the relevant proteins for parts. So your body will do the cleanup for you.
Right. And does that mean that the prostate naturally gets smaller and smaller as a consequence of this?
Yeah, a lot of the time for several months after the radiation treatment, you will notice a shrinkage in the size of the prostate. A lot of the time, the prostate becomes firmer as well because, we killed off cancer cells and we cause scarring inside the regular prostate as well. And scar tissue can feel a bit firmer than the normal kind of prostate consistency. So a lot of the time when patients come back to see us after the radiation treatments are done, we'll say, oh yes, your prostate is feeling smaller than it used to and also a bit firmer than it used to.
Yeah. But the healthy prostate cells that remain, are they growing at an accelerated rate to sort of make up the difference between the dead cells? And I mean, do they sort of?
I guess I almost wish I
Yeah.
wish they could, but unfortunately, not so much. So, and that's why you see the PSA stabilize as well, because your normal prostate cells should not be growing. They're still alive. They're, trying to do their normal function, but they're unfortunately not going to regenerate a normal prostate for you.
And are you affecting the seminal vesicles in any way with brachytherapy?
Yeah, so, with the brachytherapy, the special kind of radiation that's used does not travel very far outside of the prostate. And so it will radiate the very kind of close part of the seminal vesicles that are physically attached to the prostate, but it should not be impacting the parts of the seminal vesicle that are further away from the prostate itself.
So is there a possibility that ejaculate can survive all of this?
So, right. So I think that's one of the things that isn't talked about very much about kind of long-term side effects, because a lot of the time we talk about kind of erectile function, but, after surgery, usually you don't have ejaculate anymore because they kind of cut the plumbing. After radiation treatment, we often see patients still have some volume of ejaculate, but it is much decreased in volume compared to before. There will be some patients who don't see any volume, but your prostate, it's busy making the fluid that comes out when you ejaculate. And unfortunately, when the radiation goes in and scars much of the prostate, even though you still have some normal prostate cells that survived and can still make the fluid, it's not going to be nearly as much as what you had before. So you will see a decrease in ejaculate volume from the radiation treatment. And it's possible that you will see no volume at all, although most patients will see some.
Yeah. So the idea of seeds, and what's a ballpark for an average size prostate? How many seeds are you putting in?
Sure. So if we're talking about the low dose rate, the LDR brachytherapy, it's often anywhere between 80 to 120, very, very, very small metallic seeds that go into the prostate. For the HDR, the high dose rate, they use basically one very, very radioactive source that travels, in and out of these catheters that you placed into the prostate. And then the catheters are removed and there's no more seeds in you.
All right, and we'll get into HDR in a second.
Sure.
But the idea, so prostate, this with the low dose rate, which is where you put seeds inside, you got reduction in size of prostate. You've got the body doing its job, digesting, cleaning up dead cells. Prostate size is reduced, but you still have the original 100 or so, 80 to 100 or 100, whatever it is, that you placed initially when the prostate was full size. Have those now sort of bumped into each other? I mean, are we now got maracas inside of our body or what?
That's I like the image that you're sketching. So the prostate should shrink after the radiation treatment. treatment, but it's usually not a dramatic shrinkage, meaning, it might be half the size that it used to be, or 2/3 the size that it used to be, something more along those scales. And so, yes, the seeds, perhaps they used to be 4 millimeters apart or 5 millimeters apart. Maybe they used to be 1/8 of an inch apart and they moved a little bit closer, but they are still separated. And again, once several weeks have gone by from the radiation procedure, the brachytherapy procedure itself, the seeds are now just inactive little tiny pieces of kind of, grain, very tiny pieces of metal inside your body. They're not doing anything. They're not causing harm. So even if they shrink closer together, it does not necessarily have a biological impact on you at that point.
Right, and our body's immune system isn't attacking them. I mean, we're
Correct.
sort of and it's not like they're in our urinary tract. I mean, that would be a bad thing if they managed to get there.
That is one of the tech quality assurance factors from they should not be inside the urethra. So they should be very much contained within the prostate itself. Yes.
When you're putting in 100, let's just call it 100 for sake of.
Sure, nice round number.
Yeah, and that's all my brain can handle. So the idea of, I mean, is that 100 pokes inside the prostate, or how do you get them in there?
Yeah, so, there are different ways of doing it, but typically what happens is you have kind of a longish needle and you insert that needle into the prostate from one side of the prostate to the other. And then you deposit several seeds along the track of that needle. And so when I was talking about, the HDR radiation, I mentioned there can be somewhere, say, about 14 catheters that go in. It's probably something similar to that for LDR as well, that the number of needles that goes in is going to be a much smaller number, like, less than 20 probably. But each needle tract can have multiple seeds that are going to be dropped inside of it. Does that make any sense?
Yeah, I mean, it's basically a straw with 3 or 4 seeds in them. You put them in, and then
exactly.
What do you use, like a plunger and push them out, or how does
exactly? Yep.
Yeah.
Yeah, exactly. So, and again, these days we're typically doing them all under live image guidance, meaning we have an ultrasound or, we have something where we can see where the prostate is, we can see the seeds going in, and we're live kind of calculating, okay, where, is it where it's supposed to be? What is the radiation distribution from where that seed dropped to make sure that we're indeed giving the radiation that we intend to give?
Right. And these 20, let's call them, 20 catheter things.
Round number. So.
Yeah. Yes. Very, very important. So, and they're made of glass, right? Or something like that?
They're made of, usually they're some kind of very high quality plastic, but, they're made of different materials. So,
okay.
Yeah.
So how do you know that you're not banging into nerve bundles and cutting them?
Good question. So that's why, I was talking about the live image guidance that, decades ago, we may have done these, I don't want to say blind, but, you kind of do it without. But these days, the vast majority of doctors, there's an ultrasound probe in there. They can see the prostate. They can see the needle go in. They can see the rectum. They can see the bladder. They know roughly, hopefully, where the nerve bundles are, and they should be trying to avoid those as they go in.
Okay, so now let's talk a bit about the high dose rate, which is the same kind of, I guess, plastic or whatever that's going in.
Mm-hmm.
But you're using a different kind of seed, something with a strong emitter kind of quality to it.
Exactly. Yeah. So, the low dose rate versus high dose rate, it's referring to the seeds itself. The low dose rate, what it means is that the kind of radiation we put in the body, it has something called, it has a half-life of usually a few weeks. So meaning the radiation dose drops by about half with time as time passes, and it will take a few weeks for that radioactive seed to give your prostate the full dose of radiation that it's meant to receive. So that's how we calculated it. It has this activity when we put it into the body, and therefore it will give you this much radiation over the next several weeks. And then after that, the radiation will be low enough that we're not worried about it. It's negligible. It's not going to have an effect on your body. That's kind of how we calculated it for low dose rate. For high dose rate, the radioactivity of that kind of radioactive seed, it's very high. It's enough that it can radiate your entire prostate in a matter of minutes. And so that's why, for the catheters that we insert for HDR brachytherapy, they're hollow. They're only there as a conduit for that very, very radioactive seed to travel through. And that's why we calculate how long at various points in the catheter the seed needs to sit so that it's emitting enough radiation to the surrounding tissue so that we're end up covering the whole prostate without overdosing any of the normal organs. And so at the end, the seed comes out, it's removed, there's no more radiation in you, but your entire prostate has been bathed in radiation to the dose that we calculated.
Right. So a more, for just conversation, a more radioactive kind of seed kind of thing, or
Exactly, yes.
element, or whatever.
It would definitely not be safe for that very, very highly radioactive seed to live inside your body permanently. So
right. And
it's meant to be there temporarily.
Do you refer to it as a seed?
We usually call it as a source. So,
okay.
It's still, once again, a very small metallic kind of something that's radioactive, but you're right. We typically refer to it as a source.
Okay. So the source goes in and goes out, highly radioactive. On its way in, it's still radioactive. Isn't it? Is there potential for damage as it's going in and on the way out?
Sure. So that's why, it's connected to this, we call it kind of an afterloader, but basically I'm going to call it a robot because people like robots and they like the idea of a robot. But once these catheters are in place and we do an ultrasound or a CT or an MRI to make sure, yes, the catheters are placed in the correct position inside the prostate, the catheters are all connected to this robot, and we compute it on we used a computer to figure out where in the catheter that source needs to reside and for how long, and then it shoots at very, very high speed from the robot where the source is living because it's shielded into each one of the catheters, so that yes, there's radiation kind of going in, but it should be a very low dose because the amount of time it's spending traveling outside of where it's supposed to be is a very, very short period of time.
Yeah, it sort of raises a common sense kind of remedy for that. I mean, why wouldn't the catheter be shielded, partially, and then not shielded where it needs to be when it's inside the prostate?
Good question. And we do typically expect the workers to be outside and far away from you as well. So meaning once the catheters are placed, we've imaged, we made sure that everything is set up correctly, the catheters are connected to the robot correctly. Typically, we do not then stand immediately next to you and the catheter while the source is moving from the catheters. We will typically step away to make sure that, everything is safe. But the amount of time that the source spends outside of their calculated positions is very, very short. So the amount of radiation should be very small.
That's something I wasn't aware of. I mean, I've only seen, live and in person, like a low dose rate procedure where the radiation oncologist is sitting right at the perineum pretty much, and assistants and such.
Right, because we're picking it up and physically putting it in kind of right there. So,
but you're not in the room with the high dose rate, as you just said.
Not typically. That's right.
Yeah. I mean, but the patient is. I mean, is the patient able to be in contact with you during that procedure, or are they under
Absolutely.
anesthesia?
Yeah. So, the only time that there's any radiation is when that little source is outside of the robot. And the only time we do that is when the catheters are all connected and the robot is ready to start sending it out, kind of shoot it out to the catheter to the exact positions and then come back in. So I think, part of the concern is not that it's unsafe for us for any one procedure, but presumably the patient will go through this one time in their life, whereas we go through this on a regular basis. And so I think one exposure is felt to be safe, but if your physician is doing this, multiple times a week, week after week, year after year, it's probably less safe for them to do so. Just like when you're having an x-ray, it's okay for you to have the x-ray and you're in the room, but usually your x-ray tech will leave the room because they do that all day long.
Yeah, and we want you to be safe. So the idea of high dose rate, so less catheters catheters going into the prostate. Is that correct?
I think one of the most attractive things people like about HDR is probably that we didn't leave you with any radioactivity in your body. So, the moment that source is back in the robot, no more radiation in you. You're not radioactive for even a minute after the treatments are done. And so I think that's a very attractive kind of draw for some patients. So.
Yeah, and it's not really a new way to do things. I mean, there's the famous Andy Grove article in Fortune magazine from 100 years ago or whatever. Malecare been around for 22 years. I mean, it's an organization that's old enough to have people still talking about that being passed around. And then the high dose rate for whatever fell out of favor, or not many people were offering it. I mean, is it having a recurrence?
Absolutely. I think, for decades, LDR was the standard brachytherapy treatment for prostate cancer. It was, I would say 99+% of patients getting brachytherapy was being treated with LDR. But I think as a lot of the technology has improved, I mentioned, imaging, we want to make sure that we can see what we're doing. And also these kind of devices, these, robots that can now send the sources back and forth, and the computing technology of, where does it go? And can we compute that within a short period of time so that this is all a less than 1 day procedure for the patients? You come, you get it done, and you leave. And so you're definitely seeing increased use of HDR in this country. A lot of the time people ask which one is better. I don't think that's something that we know yet. I think they're both good. They both seem to be equally good at taking care of the cancer. I think for people who have less aggressive prostate cancers, like, low, more favorable intermediate risk, LDR brachy, HDR brachy, external beam, they're all equally good at taking care of the cancer. There is an area of controversy right now in the treatment of more high risk, more aggressive prostate cancer, because there is a trial that showed if you just do external beam radiation plus hormone therapy versus if you do external beam radiation plus brachytherapy, you seem to be better at controlling the PSA for a longer period of time if you add the brachytherapy in addition to the external beam radiation. And that can be, theoretically in the form of either LDR or HDR radiation. The thought is that you're getting more radiation dose to the prostate itself. So you're doing a better job of killing these aggressive, high-grade cancers. And so you're doing a better job of controlling it. The source of the controversy right now is that even though they have shown that your PSA will stay low for a longer period of time with the addition of brachytherapy, they have not yet shown that survival is better with the addition of brachytherapy, meaning, that you're less likely to have died from the prostate cancer 10 years, 5 years out, 7 years out, et cetera. So we're kind of waiting to see if that data matures. And yes, the addition of brachytherapy does increase the risk of urinary side effects from the radiation treatment. It's not a shocking, concept because we're giving more radiation to the prostate. So we're doing a better job of killing the cancer cells, but the cost of that is an increase in side effects. And some people feel that that's worth it, and some do not. And so I think that's an area of controversy right now where, some still advocate for just external beam radiation plus hormone therapy for high-risk prostate cancer. And some feel very strongly that, no, you should be doing external beam plus brachytherapy for high-risk prostate cancer. So neither are wrong, but I think each one has its pros and cons.
Does brachytherapy have a place for oligometastatic people who initially present with oligometastatic or metastatic prostate cancer?
That is a good question. I think right now that's not something that's been commonly tested. I think several years ago, the thought used to be that, well, once the cancer has moved outside of the prostate, into the bones, for example, then what is the point of trying to give radiation or surgery to the prostate itself? Because the horse is out of the barn, kind of, to speak. So what's the benefit of that? But now, there seems to be data that suggests that if you don't have a very high burden of cancer outside of the prostate, you just have cancer in a limited spots, like say 3 spots in the bone, that maybe it would be helpful to still go after the prostate itself and help to take care of kind of the main burden of cancer in the body. That even if we don't think we're curing you by getting 100% of the cancer, that perhaps we're helping to control the cancer by getting rid of most of it. So there is some data suggesting that. But so far, the data has really been kind of external beam radiation. And so that's been what it's focused on. If you think of the concept of, well, brachytherapy is equally good at taking care of the prostate as external beam radiation, so why couldn't you use brachytherapy? That's an interesting question, but I think just the trials haven't been done that's shown good evidence of brachytherapy in that scenario yet.
So as we close this conversation, what are the questions that you wish patients would be asking you?
Oh, good question. I think, most of the patients I see, they come with good questions. It really comes to the simple ones of, what do you think my options are? And what's the good and bad of each one of the options? Prostate cancer is definitely one where often you do have options in front of you, and everything has a pro and everything has a con. And so, and you kind of listen to that and think about, all right, what sounds right for me? I think you also want to make sure you talk to the doctor about, how many of these have you done? What is your comfort level and what are your results? I think those are good questions to ask as well. And your physician should be very comfortable talking to you about their experience and their expertise level. So it's probably hard to, I think, sometimes what I do suggest to patients is it's probably important to make sure that your doctor is doing something that they have a high level of comfort with. Meaning, if you have a strong opinion about, I want LDR or I want HDR, then you should go to someone that does a lot of whatever it is that you would like to have. But if you're going more by, all right, I like this doctor and I want them to treat me, then, maybe ask them, what do you have the most expertise doing, and going with that particular treatment. Does that make any sense?
Yeah, I mean, it's sort of an obvious thing, but when you get down to the day of the appointment, it's forgotten. Because,
sure, yeah.
At that point, it's just like when you first hear the word cancer and you don't remember the surrounding dialogue, or conversation. It's a very human and in a way healthy response, because it's really your intellect focusing on the critical, on the tiger in the room, so to speak.
Sure. And I think we, believe in empowering our patients to choose what seems right for them. And a lot of that comes to, making sure that we're providing the right information, but just also making sure that we're properly guiding them to something that is right for them and aligned with what their goals are.
Yeah. One final thing, though, that I should have put in the body of the conversation, the idea of staging, in that when you're doing a surgery, you have a prostate to do a full pathology on, and you could see what's really going on. With radiation, you're not, the prostate remains. You're going by what the biopsy, and you hope that it really reflects what's going on. What are your thoughts? Is it just the nature of the beast, so to speak, or what?
Yeah, I think that's always going to be an advantage that our surgery colleagues have over us, which is when they do a surgery to remove the cancer, you're going to end up getting more information from the surgery, exactly how large is it, how many are there, et cetera. Whereas with radiation, when we treat you, we know what we know about your cancer prior to us treating. Meaning we did a biopsy, we know what the Gleason score is, we know what your PSA is. We did scans to make sure that we didn't see any evidence of cancer outside of the prostate or, elsewhere in the body. That's what we know, and we'll be monitoring you with PSA afterwards to make sure that we did indeed cure you like we were intending to. So what I would say sometimes to kind of poke back at my surgery colleagues a little bit would be that as far as we can tell, stage for stage, even with the incomplete information that you get from radiation, you know, compared to surgery, we seem to be equally good at curing the cancer. And so, yes, you don't have more information, but your odds of being cured are the same.
Yeah, and what we've seen over 20 years of, 22 years of patients reporting back to us, even when you have a post-surgical pathology of a Gleason 6 or a 347,
Sure.
there's, it's more, I mean, we only have anecdotal reports. We're not doing like registries and such, but
Sure.
it seems like same level of recurrence, no matter whether the post-op was pathology was elevated and revealed a Gleason 8 or 9, as opposed to like a 6 or 7, or it just was a 6 or 7. But the same number of patients are saying 5 years down the road or 6 years down the road, PSA goes up, I'm on ADT or hormone therapy. So I mean, everything's a crapshoot in this. I mean, and.
I will agree with your crapshoot statement in the sense that, when we see our patients, a lot of the time you hear a lot of numbers and statistics, right? There's a 10% chance of this and a 5% chance of that. In reality, there's one of you. And so things either happen to you or they do not. And maybe it's reassuring to know, oh, there's only a 1% chance that bad thing will happen. But if it happens to you, that's 100% of you that it's happened to. And so I think I think the numbers and percentages are important to help guide you in your decision making. But it's also kind of important to be mindful that yes, sometimes it may be that I will be the best case scenario or I will be the worst case scenario, and you have to be mentally willing to accept that as well.
Right, and to understand whatever you choose when you've come to a well-considered choice around treatment, you've done the best you can.
Right.
I mean, if you're privileged to live in a developed country where brachytherapy is available and really good doctors are available to do the procedures for you or with you, I mean, you've done the absolute best you can possibly do in 2020, 2021. And whatever happens down the road, I mean, that's, you've done the best. There's you did not mess up,
Right.
and that's really how life is, I mean, this is what's on our plates,
And I think that's something that I discuss with my patients as well. A lot of time I say, I actually don't have strong feelings about which treatment you proceed with because these are all good options. It's up to you to choose. But I think it is important that you don't regret your choice, that, whatever you decide to proceed with, you know to yourself that I thought about it, that's what I picked, and we will do our best to make sure that you're going to have the best outcome from that. But you can't go back in time and choose differently. But if you thought about it and you're committed to it, then usually the odds are in your favor that it will work out well.
Dr. Zeng, thank you for this wonderful conversation. Thank you for taking care of your patients as well as you do, and for taking care of our community with your research and your insights, and for sharing them with us. And welcome to our conference.
Thank you. It's been a pleasure, and feel free to reach out to me if you have any further questions. So,
okay.
Take care.
Okay.